Chair Shelley Bailey,
Here.
Vice Chair Amy Burns,
Here.
Dan Hartung,
Here.
Lori Hoagland,
Here.
Robert Judge,
Here.
Chris Lehman,
Here.
John Murray,
Here.
Dan Kennedy.
Here.
We have a quorum, Chair Bailey.
Perfect. Thank you, Melissa. I would now like to ask my colleagues on the board here today if anyone has any declarations of real or perceived conflict of interest that they'd like to share today. Mr. Murray, I see your hand raised first. You have the floor.
Yeah, thank you. Thank you, Chair Bailey. Under advisement from the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs. I have contracts with the state of Oregon, PBMs and insurance companies to provide pharmacy services. I'll use the Ethics Commission wording because the PDAB is an advisory board that simply provides information to others who have rulemaking authority. Guidance from OJAC is that it appears that at most you would have a potential conflict of interest each time the PDAB meets. Thank you.
Mr. Murray, thank you for your declaration. Mr. Robert Judge, your hand was up next, I believe. You have the floor.
Thank you, Chair Bailey. Given my professional role in pharmacy at Moda Health and my simultaneously services with the PDAB, I recognize that there may be potential conflicts of interest that may arise. I'm committed to the upholding the highest standards and will diligently adhere to all applicable laws and regulations. However, should any potential conflicts arise, I'll promptly disclose the details to the board and seek guidance on appropriate next steps, which may include recusal from relevant discussions and votes.
All right, Mr. Robert Judge, thank you for your declaration. Mr. Daniel Hartung, you now have the floor.
I just wanted to disclose that I have consulting arrangements with the National Multiple Sclerosis Society to support some of their advocacy work. And I noted that they have some public comment today. So just disclosing that relationship.
All right. Thank you very much to my colleagues for your disclosures. I would now like to ask if any members of the board have any changes to the draft minutes from the August 21st, 2024 meeting. Okay, so if no one has any changes to the draft minutes, I would like to ask for a motion and a second to approve the minutes.
This is Dan Kennedy. I so move.
Thank you, Dan Kennedy. Mr. Robert Judge, your hand is raised.
Second.
Okay, Mr. Judge, thank you for the second. Melissa, if you could please call roll.
Dan Hartung,
Aye.
Lori Hoagland,
Aye.
Robert Judge,
Aye.
Dan Kennedy,
Aye.
Chris Lehman,
Aye.
John Murray,
Aye.
Vice Chair Amy Burns,
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Perfect. Thank you, Melissa. I would now like to call on Executive Director Ralph Magrish to provide us with a program update. After the update, Ralph will move into a discussion from an OHSU presentation and introduce our OHSU guests that are here with us today. Ralph, you have the floor.
Thank you, Chair Bailey. Lots going on, but first I want to take a moment and welcome Lori Hoagland to the PDAB for her very first meeting. Welcome, Lori. After being confirmed by the Senate last week, we now have a fully seated board once again, and very excited about that. And we welcome Lori. She is from Ashland. Just a little bit about Lori. She's worked as a nurse practitioner in primary care for the last 38 years in both California and Oregon. She's managed patients at Kaiser in California, where she also worked as a quality liaison addressing gaps in care in clinics for 18 years. She is bilingual, speaking Spanish, and served a variety of patient communities for the last 12 years. Lori has worked at an Oregon FQHC, seeing patients of all ages in their clinic, on a mobile van, and in schools. So we're delighted to have this FQHC representation and perspective on our board. We also want to take a moment and congratulate Board Member John Murray and Vice Chair Amy Burns for their reappointments to the board and thank them for their willingness to continue serving. So gratitude and welcome, board members. If you will, please welcome Lori to the board. Couple other things going on, and very pleased to announce that the new pharmacy benefit managers reporting requirement that was created under Senate Bill 192 that had a requirement for DCBS to begin posting PBM data that we collected by October 1st. That page went live on Friday rather. As a reminder, that was a data collection effort of PBMs in Oregon as to the total amounts of rebates, fees, price protections, and other payments they received from manufacturers as it related to administering a benefit here in Oregon. That included all payments from manufacturers directly and any other payments by the PBM subsidiaries or any other entities that the PBM held ownership in. Also including amounts totaled passed on to insurers in Oregon, total passed on back to enrollees, and the total amount retained by PBM as profit. Also pleased to tell you that 2 weeks from today, we will have Taryn Hines, who's the research analyst for the Drug Price Transparency Program, do a presentation to you, the board, on that data set. So looking forward to that and welcoming Taryn to do that for us. If I can now, I'd like to go ahead and introduce OHSU. I did see that Rhonda was with us, but to my knowledge, I think it's just Susan and Beth presenting. If it's Rhonda too, we will happily promote her as well. With that said, board, let me please welcome Beth Shaw and Susan Stewart from the OHSU Center for Evidence-Based Policy to present to the board at my invitation today. As some of you know, the center supports a number of states in their Medicaid work through the Drug Effectiveness Review Project, or the DERP, and other initiatives. A little bit of context for today. Early this year, the center reached out to all of us PDAB states to see if there was interest in establishing a multi-state collaborative. Short version of that is that as each state was on its own trajectory and varied timelines, that didn't really prove to be something that was viable right now. But in that same context, here in Oregon, knowing that we are not renewing our contract with the portal team at Harvard for technical assistance, and that we will still likely receive some assistance from them through a grant that they are funded through the National Academy of State Health Policy, I did want to create this opportunity for the board to hear from the center this morning as to what their offering might be to assist us going forward. So with that said, if I can welcome and introduce Beth and Susan, take it away.
Great. Thanks so much, Ralph. And thanks to the board. This is Susan Stewart. Ralph and the PDAB staff team, we would actually love to include Rhonda Anderson in the presentation. So if it's possible to promote her on the fly into speaking status.
Yep.
Yes, I did promote Rhonda. So
thank
see
you
if
so
Rhonda
much.
can use your camera now. Give that a try, and your mic.
Okay, great. So I want to say thanks to the board for giving this opportunity to sort of engage with you all today. Again, I'm Susan Stewart. I'm the Director of Technical Assistance at the Center. I'm joined by my colleagues Beth Shaw, who's the Research Director, and Rhonda Anderson, who's our Director of Pharmacy. Let's go to the next slide. We're, just went through sort of a little bit about us. Rhonda's going to walk through just some quick background at the Center for Evidence-Based Policy, situated at Oregon Health and Science University. And then Beth and I are going to talk to you a little bit about ways in which we support state public bodies and decision-making entities sort of in other states and other types of roles. And we're going to try to connect that to, options that could be of interest to the Oregon PDAB, not necessarily, but we're going to lay that out and have a quick discussion and see if anything is a fit. So I think with that said, I'm going to hand it over to Rhonda, and we're going to go forward to the next slide.
Good morning. Let's go to the next slide. We've already done our introductions and talk a little bit about the center. The Center for Evidence-Based Policy has a mission of addressing policy challenges with evidence and collaboration. We were established in 2003 and are housed at Oregon Health and Science University. Our work is driven by states. We are state-facing, typically to Medicaid. We have no biases. We're not funded by industry or associations, but we do have 2 grants. One facing pharmacy through Arnold Ventures, where we do a bunch of state technical assistance. It's called Smart D. And also a grant with the Commonwealth Fund, where we produce the health equity scorecards. Let's go to the next slide and continue to talk about the center. In the last couple of years, we've worked with over half the country, putting our stamp in 37 states, providing them with robust evidence and technical assistance to help them with difficult policy challenges. We're nonpartisan. We don't lobby. And what we do is apply the most robust data and evidence to these decision makers to help them whittle through the decision-making process. Typically, we do not publish. So our reports, you won't find them in peer-reviewed journals, but we do provide robust methodologically sound evidence to our state members. Let's go to the next slide. Our work typically falls in 4 buckets. You'll see them here on the slide. Let's talk a little bit about starting at the far left-hand side. So we run nationally renowned multi-state collaboratives. I'm the director of one, which is the Drug Effectiveness Review Project. You guys are probably very familiar with that, as Oregon is our founding member state. It is front-facing to pharmacy in Medicaid. Then the sister collaborative is Medicaid Evidence-Based Decisions. So it's all the other areas of Medicaid. And that's a membership-based, these are membership-based collaboratives where states pool their money together and get robust evidence and technical assistance to help make these difficult decisions. The next bucket that we categorize our work in is health process and systems engineering. Here you'll find that we do stakeholder engagement, public process development, strategic planning. These are areas that states find themselves without enough bench, and we typically are able to help them develop internal processes to better address policy challenges. The next column over is data analysis and public evidence dissemination. This is like the stalwart of what we do. We have a robust data team and provide public evidence for things like the Oregon Child Integrated Data Set, which is a huge data set that comes from a ton of different Oregon departments, and it's all about children's data informing policy across state government. Also, the health equity scorecards I talked about before, sponsored by the Commonwealth. Take a peek at those on the website. It's really some incredible work. Then last but not least is our single state evidence assistance. We're well known for our evidence development and sound methods to produce this robust evidence. And that leads me to our next slide, which I think I'm passing it to Beth.
Maybe. Yeah.
No, to Susan. All right.
Great. Okay, so we're going to get down partially to brass tacks here. Beth Shaw and I are going to talk to you a little bit about the options that the center has available to support the Oregon PDAB if there's interest. So let's go to the next slide. So I'll talk a little bit about the process and systems engineering side of the work that we do. And my colleague Beth Shaw is going to talk about the evidence assistance that we're capable of providing. So as we talk about process and systems engineering, I'm really framing this from the standpoint of how does a government agency, a public committee, a public board sort of work through decision-making processes, through stakeholder engagement, and if it's needed, strategic planning. So let's go forward to the next slide. We've done this work in many states. I'll give you some examples on the next slide. When we do this work, we think about it in 8 categories. I just want to say right up front, I don't think we've ever done work in all 8 categories with a specific state on a specific committee, public decision-making process or board. Usually what we end up doing is engaging with a state around 1, 2, maybe 3 of these issues. So let me just walk you through them briefly. We find that public facing bodies, whether it's a Medicaid agency making coverage decisions or an evidence review committee, can occasionally need help around decision-making algorithms. Sort of, what does the process for decision-making look like for the public body, and how can you make that extensible and transparent, not only to the body, the board itself, but to the public and the community of stakeholders that want to engage with that. So we can support sort of a process and systems design process for that. That's related to bucket 2 as I move here along the first row, which is really system mapping. What's the information that maps into this decision-making process? What data, what evidence, what stakeholder input, what other, informal pieces of input map into this process? What does it look like? And we sort of called out here sort of cost driver decision points, knowing that that's something obviously specifically that you all are grappling with as the PDAB for Oregon. We can and do support if a state wants this, a strategic planning process, to be quite simplistic about it, helping a state for a public body or decision-making process, evaluating what's going well and how do they fully fulfill the regulatory or statutory sort of scope of work, and also evaluate what they feel is going less well and what steps can the entity take to address those and adjust its trajectory. We will work with a public decision-making body or process around its deliberation methods. So how do you evaluate the different pieces of evidence and data coming in? How do you think about, in an informal way, weighting those? Does that need to be a formal process? How do you think about risk of bias? And how does the group sort of publicly undertake deliberation and take sort of stakeholder input? And that moves me pretty quickly down to the bottom row here. We will work with state entities on how they engage with stakeholders. How do they get stakeholders to activate and be involved in the process? And how do they make that happen? And I think importantly, as I move along the bottom row here to this second area, how do they make sure stakeholders understand how to interface with the decision protocols that the public body is using? At what points can stakeholders engage? At what point can they give input? How can they understand the steps in the process so that they can feel enfranchised and engaged in what's happening? If it's needed, we'll do, board member, committee, or work group training. This is sort of very ad hoc in nature in terms of the specific request that comes in. And we can do clinical and process consultation on an ad hoc basis. I find we do more clinical consultation that a group or a public body needs a physician consultation. It needs consultation from a pharmacist. It needs consultation from, a genetic testing counselor. And those are resources that we're able to provide if that's necessary and appropriate to the process. So next slide. So just an example. So we do work in those 8 areas, and we've deployed those skills in a bunch of different states and processes. We helped New York set up the protocols and the membership for its evidence-based benefit review advisory committee. And we still do evidence review and synthesis to them for this day. We worked with Texas Health and Human Services Commission around sort of designing their coverage determination process. How do people give input into that and make requests? How do they review evidence? We work with Washington HCA on their health technology assessment program. Louisiana Medicaid, again, doing design work around coverage determination and that public process. We work with the HERC here in Oregon, and with Colorado as an example, a little more cost and financially oriented on their all-payer global budget work group. So it just gives you an example of where we've deployed some of these skills. So I think with that said, I'm going to hand the microphone over to Beth Shaw. She's going to quickly walk you through the evidence side of our capabilities, and then maybe we can have a teeny bit of dialogue.
Thank you so much, Susan. So my name's Beth Shaw. I'm one of the research directors at the centre, and my specialty is really in evidence synthesis and methods. So on the next slide, you can see kind of how we've been thinking about the type of information that you would need to be thinking about when you're determining, drug affordability. So in terms of this, we're kind of phrasing this as a drug context review. So this is really thinking about all the kind of information that you might want to know about the drug under question. So of course, we would provide an executive summary that summarizes all the information. We have a background that kind of, introduces you to the disease, to the drug and its use. We would provide information on benefits and harms. How effective is this drug? What are the side effects profile associated with it? We'd like to provide you information on health equity. What are the equity and health inequality aspects associated with the disease under question? We'd like to provide you with information about therapeutic alternatives. What else can be used in this space? Again, that information on disease summary, place in care. So very importantly, where does this drug sit in the care pathway? Is this a first line drug, or is this something that only tends to get used after other options have been explored? We think very importantly, there's information about patient and caregiver perspectives, as well as a summary overview. So we're thinking about this in two different ways, kind of a bare minimum approach, what is the minimum kind of form of information, and where there's an enhanced option, a bit more information that may help you in your deliberations. So on the next slide, you can see more information about each of these elements, and I'll run through them quickly. But just to know, on the right-hand side of this slide, you can see how this links to the legislation that underpins the Oregon PDAB. So just going through those kind of elements again, we've got that background. So that short overview of the drugs or drug of interest and the indications for use. We'd like to focus on some of the benefits and harms. So this would kind of be a bare minimum, the summary of data used for approval of each drug of interest. And we'd use various sources for that, primarily information from the FDA on how they approved that drug and what was important to them, as well as online sources such as databases of pharmaceutical information, such as IPD analytics. We can also look at a summary of selected effectiveness sources. We can agree this with you, but we're talking about kind of really well-respected sources of evidence, such as Cochrane reviews and health technology assessments from major organisations, such as ICER, the US-based institute, and CADAF, based in Canada. An option for this would be to look at relevant published studies identified from searches and reference lists. This would not be a full systematic review, so we would not be doing things like risk of bias or grade or assessment of the certainty of evidence, but we could provide you an overview of the studies looking at the drugs of interest. We'd be looking at health equity. So again, that rapid review approach of looking at the health equity issues related to the drugs of interest, which may include cost as a factor. Recently, I'm sure you all are aware of the debates about the cost of insulin. So we could look at things like that, how they're barriers to accessing certain drugs. Obviously, of interest is what else is available in this space for people. So we'd provide an overview of the FDA-approved therapeutic alternatives, again, using sources such as the FDA and online sources. As an option, we could also look at pipeline therapies. So these are therapies that are not yet available, but may be available in the near future. In order to understand the drug, of course, you have to understand the disease summary. So we'd provide a short overview of the condition or conditions of interest, specifically giving you information about US prevalence, mortality, morbidity, and other key information about that specific disease. We think it's important that you think about the patient and caregiver perspectives. And again, we could provide a rapid review on that, particularly thinking about differences between the therapeutic alternatives. For example, route of administration. You know, do people mind injections once a day, or do they prefer an oral therapy? What are the issues that are really kind of driving patient or caregiver decisions in this space? As mentioned, we'd be talking about placing care. Are these first line, or are these more for third line kind of use? So we'd look at a summary of selected clinical practice guidelines where they've really looked at the evidence and thought about where these therapeutic alternatives lie on that care pathway. And again, a summary of those to summarize all that information. So on the next slide, you can see that just kind of methods is my jam, as it were. So there's lots of methodological discussion that goes into this drug context review. What we would really like to hear from you is where you think that threshold of evidence needs to lie to support your decision making. We talk about evidence. We can do rapid reviews. We can do reviews that take 2 to 3 years. You know, they all use the same principles, they use slightly different approaches to provide that evidence. We think you need a kind of rapid review approach. You need to make these decisions in a timely manner. So that's why we're proposing using key sources of information. So we'd not necessarily go to that primary evidence, i.e. the original published studies, but we'd be using other people's summaries of that evidence and their assessment of it. We wouldn't be providing formal critical appraisals, so we wouldn't be looking at those individual studies and providing risk of bias information, nor would we be providing that formal assessment of the certainty of evidence that you often see in full systematic reviews or in guidelines. So we wouldn't be providing grade ratings, for example. And how you use that evidence in that board process really goes to, I think, the heart of what Susan and Rhonda were talking about. You know, how do we build this evidence into your process? And, you know, the evidence that you need links to the process that you use, and the process and the decision-making approach takes links into the evidence. So it's all kind of interlaced into that. So just to make that connection. And thank you. I think I'll hand it back to Susan.
So to the board and to Ralph, this is the information that we wanted to share and thought might be appropriate. We'd love to take questions or feedback now, or we can certainly leave it for you all to discuss with the PDAB staff, and you guys can follow up offline.
Mr. Judge, looks like you had your hand up first, so you have the floor.
Thank you, Chair Bailey, and actually Amy's probably got a smarter and more intelligent question, but I get the fact that based upon your, and let me first say thank you very much for this presentation, the information you shared, and your reputation precedes you. You guys do great work, not only in Oregon, but in other states as well. But my sense is, since you're primarily in the Medicaid space, you really have no engagements with other states on kind of helping them figure out upper payment limit strategies and how to look at this. So if we think about our mission, which is really to identify drugs that may present affordability challenges both to patients and payers, can you give us some insight on how you may have worked with other states or entities on looking at data to help them inform cost containment strategies for prescription drugs. Because that's kind of where, our focus is needing to be, less on kind of the clinical body of knowledge that we need to understand on therapies, but more about because we don't make any decisions on whether a drug should be covered or not being covered. We know that it is covered, and then our task is to figure out if it presents affordability challenges. So can you give us some insight on how you think about that challenge as the Oregon board needs to think through this?
Sure, I'll start and can let others jump in. I think our thought with regard to the evidence, Robert, is that the evidence and the context for the drug stands, without respect to line of business and payer, and that situating the drug in its context is perhaps quite useful as you're deliberating about affordability, patient and caregiver perspectives, placing care considerations for health equity, and sort of how these things play out, I think are important in the context of thinking about affordability. I do not want to step on the role of your staff, which I think is actually really quite expert in analysis of the cost data, but should they want that, we're certainly willing to be a thought partner and have some very reasonable experience doing cost and claims analysis specifically on drugs using state all-payer claims data sets in more than one state. So that's absolutely something that we could discuss, but I do think your board, the staff to your board, is quite expert in this area from what I've seen so far.
Thank you.
Thank you. And Vice Chair Burns, you have the floor.
Yeah, I kind of had the same thought as Robert, so he expressed it quite well about work within affordability and actual cost context. So thank you for answering that. My follow-up question then is, how do you envision this working with the staff? I'm having trouble seeing how that connects.
Ralph, do you want me to go first, or would you prefer to talk about?
Yeah, no, I will for a moment.
Yeah.
Thank you, Susan. And I'm also mindful of our larger time, and I think this probably gets us there. But the short version, Amy, I think, is that, very logical nexus between the work that they do at the center and a lot of the work that we do. And in fact, when I first heard their presentation to the potential multi-state group, the things that kind of stood out to me, and they hit it front and center today, in fact, were the work around health equity and decision-making algorithms and kind of a thought partner. And all of those resonated in the construct of, candidly, the challenges that we as a board and staff have had in our maturation curve over the last couple of years. So it was really a matter of kind of welcoming them to this forum. I think a lot of that would be really TBD based on your preferences as board, minding that we are really here to support you. So what I think I would say is that if there were interest by board for us to pursue this, that we as staff would go ahead and with Chair Bailey at our side, potentially seek a little more formal kind of proposal for them. This is really just an opportunity to get them in front of you. So to that point, Amy, answering a question with a question, I guess if there were specific pieces or weaknesses that you felt like we either as a collective program had or deficits that staff had, that the skill sets and experience that the center brings would be complementary to helping us advance our goals, those are the things that we would dig into. So hopefully that's a reasonable answer for you.
And Mr. Judge, you have the floor.
Yeah, Ralph, thank you for saying that, because that was one of the kind of the notes I made as I was listening to the presentation, especially around health equity. And if there's a specialty in this area, we know it's an area that we're working to try to get our arms around and do a good job with. That might be for the board something that we'd want to consider Because I think it will only enable us to look at information more broadly.
Something else that caught my attention and kind of listening to the rapid reviews format was also related to disease summaries. You know, I particularly would be interested in kind of cost of care. And I was interested in kind of what some of those secondary sources would be that you would use for that. But to me, that seems just personally part of additional enhancement that we could use, you know, kind of support on from my perspective. Vice Chair Burns, you have the floor.
Yeah, just to kind of pull a little bit on that thread, and maybe I misunderstood, but if we were to get that kind of information from you based on the evidence that you gathered and reviewed, you wouldn't be doing any work on grading or bias, though. So we wouldn't know whether or not the evidence that you were looking at was, say, of high quality or low quality. Is that correct?
Yes, we wouldn't be looking at those primary studies, but when an HTA organisation, for example, has produced that health technology assessment report, they usually provide information on their assessment of the quality of the evidence. So we could provide that information, but we wouldn't be doing that ourselves in that rapid review situation.
Okay, that makes sense. I'm sorry, I didn't understand that. Yeah, I think that would be really important, because if we are looking at, as you know, Chair Bailey was saying, reviews and more information on disease states, place of therapy, I think we always have a lot of questions on total cost of care, things like that, which is really challenging to answer. We would want to know if what we were looking at had, you know, good ratings, good evidence behind it. So that's helpful. Thank you.
Thank you.
Lori, I see that you have your hand raised. You have the floor.
My question is, looking at this, maybe taking one medication and trying this process to see how it looks and works. And then secondly, or is it just we decide to go this route and everything is handled in the same way? The second thing is timing. How long would it take for you to handle, for instance, one medication in this process?
Oops, Susan, you're on mute. And we'll need to probably make that Lori's the last question, then move on with our agenda.
Yep. Hey, Beth, would you take the latter question about amount of time for the rapid review?
Absolutely, I can take that. I would say a rapid review can take as long as we have to do it. So, you know, I've worked in institutions where a rapid review would take 3 weeks, or a rapid review can take 3 months, 6 months. That's really where we I mentioned, you know, a report could take 3 weeks, or it could take 2 years. The same principles apply. We just do things in a slightly different way to get as quickly as we can to that answer. So it's flexible from our perspective. We would be kind of driven by your needs, really, and that would involve, you know, maybe discussion about where do we put most effort if it were a 3-week review versus a 3-month, 6-month.
If I can, Chair Bailey, I think first I want to express great appreciation to Susan, Beth, and Rhonda for coming and speaking with us today. What I'd like to do, and absent the need for any kind of formal vote, would be to see if there is interest by the board to direct staff to have additional conversations with the center to potentially have them come up with a little bit more of a formal proposal, now that they too have a construct of some of the things that I think are probably of more keen interest to you, and we would work with Chair Bailey there. So I think that is the question that I would put to you. The board is if you would like staff to pursue this a little bit with the center to bake something of a little more substance on their part to bring back to you in terms of a proposal to react to. And if the answer is no, that is okay too. This is not a hard sell, and that's a conversation that we had very early on with the center. Felt like I would be remiss in my my job if I did not try to make this association and give these folks opportunities to speak to you, the board, to see if you felt like they might have a role in supporting your work. And if we could, I'm going to suggest just by an informal virtual hand kind of process, if there is interest in having staff pursue this a little more discussion with the center, or real hand if not able to. And I'm seeing 1, 2, 3, 4, 5. It looks like all right, a thumbs up and. So great. All right. Well, I think that's going to wrap this up. Center folks, gratitude for your coming and spending some time with us today. Staff, we will check in with the center folks in the coming weeks, and we will work with Chair Bailey to get something on the calendar down the road for them to come back. And again, we thank you very much. So appreciate it.
Thank you.
So we are now going to move forward with the Medicare MFP modeling presentation portion of our agenda. So at the August 21st meeting, the board heard from board consultants Myers and Stauffers and discussed the draft constituent group engagement report. Today, Myers and Stauffers will present concepts for implementing upper payment limits in Oregon, and staff will discuss a savings model. The board will discuss these concepts and give feedback. I will turn it over to Ralph to help start facilitating this discussion.
Great. Thank you, Chair Bailey. And our plan for the next hour and change, we will talk about some of the modeling that we have done with the Medicare maximum fair price numbers, and then move into specific analysis as it relates to PEB and OEB, and then into our substantive conversation. So quite a bit to cover here. As I shared with you back in August, that I had asked staff to work up a modeling exercise to see what possible savings could have been realized in Oregon as upper payment limits had the state had authority, had the maximum fair prices that were announced been applied to calendar year 2023, and you will hear from our staff, from Courtney and Heather, on that just very shortly in that repricing exercise that they have done. Before I turn it over to them, I just want to provide a little bit more context for this analysis and the Medicare maximum fair price numbers in general. Some statistics. It was reported by Reuters on September 3rd that the U.S. government's first ever negotiated prices for prescription drugs are still on average more than double, and in some cases 5 times what drug makers have agreed to in 4 other high-income countries. Recent report by pharmacychecker.com said that the prices for these drugs after this negotiated maximum fair price are still 4.7 times higher than that of the United Kingdom's National Health Service. And a recent Kaiser Health News article stated that more than 50% of what Medicare spent on drugs from 2016 to 2018 was for drugs that were advertised on television. That same article noted that half of the 10 drugs targeted for price negotiations this year are among the drugs with the largest direct-to-consumer advertisement spend. And we give you all of this just in context that the potential impact of upper payment limits and savings can have, not just on out-of-pocket cost at pharmacies for consumers, but for premium increases, for hiring and growth decisions for small businesses, and the ability to give employees a raise or a cost of living adjustment. So all of these things are things that we would encourage you to consider going forward as you contemplate upper payment limits. With that, if I can invite Courtney and Heather to share their presentation.
I'm going to share my screen. All right, can everybody see my screen? Yeah, okay, great. So good morning, board. Before discussing the upper payment limit modeling, we wanted to show you the analysis that was done with the Center of Medicare and Medicaid Services, or the CMS negotiated maximum fair price list. Also a little bit of background. On August 14th, CMS provided an update on its progress in the Medicare drug pricing negotiation program. And this program stems from the enactment of the Inflation Reduction Act of 2022, which affords CMS the ability to directly negotiate the prices of certain high expenditured single source drugs without generic or biosimilar competition. The CMS released the negotiated prices for the drugs shown here which are the first drugs on the maximum fair price or the MFP list. What we did was took the 2023 carrier report submitted to DCBS under ORS 743.025 and did a pricing exercise with the MFP pricing. And just as a reminder, the board decided to not review these drugs during the affordability review or review any drugs on the MFP list. So this exercise kind of shows what the potential savings for Oregon would be for those drugs. I'm going to turn it over to Heather now to provide additional information on the analysis and how we come up with these savings numbers. Heather.
Thanks, Courtney. So basically, the PDAB was looking or maybe able to draw some parallels with the CMS maximum fair price and model similar effects, kind of what Ralph was just talking about, if an UPL was used in the state. And so the analysis is examining potential savings using the CMS negotiated drug price. And in what you're looking at, that would be the price represented in orange. It's important to note that Courtney touched on just a little bit as well, is that this analysis isn't a one-to-one market comparison. It is limited to the commercial insurance carriers that reported to the Drug Price Transparency Program for 2023. So the Oregon data then includes specific plan types like large, small, and individual, and excludes Medicare, Medicaid, self-insured, PEB, and OEB. The table that you're looking at shows Oregon's carriers' annual expenditure based on the number of prescriptions and the number of enrollees for a drug based on the wholesale acquisition cost. And these sections would be the ones highlighted in blue that you see there. Those expenditures, those annual expenditures, were then recalculated using the Medicare MFP, again, the number in orange, to arrive at the potential cost savings calculations that are shown in purple. That also includes the percentage savings in the last column that could potentially be afforded by the maximum price. Each drug in this model demonstrates a significant potential cost savings. And with that, that's a brief overview of what each of these columns represents. Again, the blue is the data we've collected through DPT, orange is Medicare, and purple are the recalculations based on the CMS negotiated prices.
That overcap. Board members, who I hand it back to Ralph, did you have any questions about this analysis and the potential savings? Yeah, Robert, I see your hand. Oh, you're on mute.
Thank you. I didn't see I was muted. Just a question, and yeah, I think how do I say this? This is a good mathematical exercise, but I'm not sure what's the intent of the staff in showing this information. Because is it to say theoretically, if we matched MFP for an upper payment limit, this is what we could look at? I'm just not sure how to think about this.
Sure. So Robert, I can take that. This is in fact a limited repricing exercise based on paid claims and net of rebate spend. And that had the state of Oregon had upper payment limit, lots of hads, had the state of Oregon had upper payment limit authority in 2023, had we been able to set rates for the same universe market basket of drugs, had we set them at this Medicare MFP in 2023 versus what was paid net of rebate, a gross or net savings rather of $49.1 million would have been realized. That is the extent of this exercise as a repricing exercise.
So there is what the what your data is showing here. There's okay.
And that was, just to be real clear, that was the limited and narrow intent of this exercise.
Got it. Thanks.
Ralph, back to you.
Sure, thank you. And as we move into our upper payment limit modeling from PEB and OEB and the Oregon Health Plan as it relates to Senate Bill 192, and Melissa, if you would kindly go ahead and share screen and put up that beginning of that executive summary. So board, I'm going to move through this fairly quickly as this analysis was completed at the Oregon Health Authority with the assistance of its actuarial contractor. I am not well positioned to answer questions on this analysis, but encourage you to read the breadth and depth of all of the information provided. And to that point, certainly want to thank our colleagues at OHA and their vendors and their support for preparing this information. So to that point, based on a market basket developed by Myers and Stouffer, 3 reimbursement scenarios were created for upper payment limits for 8 prescription drugs to consider in this modeling and analysis. This set of drugs was pulled from the 2023 PDAB prescription drug top subset list. It included Cosentyx, Entyvio, Inflectra, Keytruda, Ocrevus, Ozempic, Tremfya, and Trulicity. All of those scenarios are at the end of this section, as you can see. And again, you're encouraged, please go ahead and review those at your interest, time, and convenience, and anticipating that you have done so already. And to that point, we're going to be very transparent throughout the entirety of this process, as we are with everything we do, and state the obvious. These analyses are heavily caveated, and thus acknowledging may be of limited value. However, indications suggest that UPLs could generate significant savings for these 2 programs. And to that point, Melissa, if you will just stay there for just a sec in the observations point. So under the, actually, if you will go back up, Melissa, sorry, keep on to the top page. There you go. One more, sorry. There we go. Great. Thank you. So to this point, under the PEB-OEB analysis, with the footnote of number 1, under this scenario where it is assumed that there would be no rebates due to an implemented upper payment limit, the likely outcome range for could represent a combined increase in plan spend of over $12 million, where there is the modest price reduction that would be less than existing rebates, to a cost savings of $17.8 million. Again, that is when price reduction exceeds existing rebates, and you have the delineation for PEB that could be an increase of $8.9 million or 1% to an overall savings of $10.7 million. For OEB, similarly, cost increase potentially of $3.1 million or a overall savings of $8.1 million. And then the following scenarios that include assumptions of 25% to 50% of rebates would be maintained or retained rather. We note for you that the potential increase in PEB could be a cost of $3.6 million to a savings of up to $20 million based on the UPL selected. And for OEB, a $0.2 million savings, or to a $13 million, almost $14 million savings based on the upper payment limit selected. And Melissa, just pivoting, if you will scroll down just a little bit to the Medicaid Oregon Health Plan data set. OHP has advised that reductions in cost in implementing an upper payment limit would likely be reinvested in other OHP services rather than directly reducing costs for the state. With that said, for the fee-for-service program, for this small universe of drugs, likely an anticipated savings of $1.1 to $2.3 million, and for coordinated care organizations, an anticipated savings of $25 to $56 million. It is worth noting for you, if I can ask Melissa, you just go back to the top of the next page, please. I'll speak to the methodology, pivoting back to the PEB and OEB analysis, and I'm going to read this piece out loud to you. It is expected that the reduction in the point of sale drug prices due to upper payment limits will result in lowered or eliminated rebates. Because of this novel approach, the rebates retained with upper payment limits in place are uncertain. To account for this uncertainty, the 3 different UPL scenarios were modeled with no rebates, as well as 25 and 50% of the current rebates retained with the most conservative estimates being that rebates for the affected drugs were eliminated upon implementation. This analysis never allows rebates to exceed the ingredient cost for a drug or scenario combination. So again, to you board members, I'll say not well positioned to take or answer questions on this. If at a later time you would like a detailed dive, we can try to see if someone from OHA could join us for a presentation. But again, encourage you to read this if you have not already. But again, heavily caveated, but the overarching theme here is that we would anticipate to see savings. So I thank you for that. And unless any other issues or things that we need to address, I will move right back into the continuation of this section with the upper payment limit planning conversation. So here we go, team and board. As we start this conversation over the next hour or so, I do want to level set with you on the scope and the realities of what the ask before you really is, and that we have been tasked to develop a plan to implement upper payment limits in Oregon. You also know that we have the benefit of watching several other states having gone before us, and specifically I'll note that the Maryland board just met recently and completed its upper payment limit action plan for government payers. In Maryland, that plan will need to be reviewed and approved by the Legislative Policy Committee within the next 45 days. However, if approved, that means that staff would begin to investigate various avenues to lower prescription drug cost, with upper payment limits being one of those options if staff determines it to be most effective. I would call this deliverable in Maryland, quite honestly, quite analogous to our Senate Bill 192 upper payment limit planning and implementation report. And to that point, I just want to share with you a couple quotes from members of the Maryland board at that meeting, with the intention of potentially easing some of your anxiety about the level of detail necessary in our report and that we're able to develop at this moment in time. So one Maryland PDAB member said, "Each drug is unique and probably will require a slightly different approach." That board member went on to say, "Even when you have a process that's committed to transparency and a methodology and talking about the rationale for why you elevate one method or another, no method is uniformly best. And so until you start and you stress test that process, you can't even improve upon the methodology and your process for selection." So hopefully that gives you a little bit of context that as we go forward, I'd offer this to you, that we think of this as establishing a structural framework for upper payment limits, not an in-the-weeds process document for selection. And to that point, I'd even point and reference a couple of statements that Pharma made in its comment letter of September 15th as yet another reminder of what we already know, that this is in fact a slow and deliberative process. Pharma says, and I quote, "If UPL authority is ultimately enacted by the Oregon Legislature, the Oregon Administrative Procedures Act requires that separate rulemaking be conducted to establish the specific definitions, standards, and processes that will govern any upper payment limit process. Even if granted that statutory authority to impose upper payment limits, the board could not implement an upper payment limit consistent with the requirements of the APA unless the board first adopts comprehensive regulations governing each procedural step, factor, and methodology described in the draft UPL approach document through notice and comment and rulemaking." So a long runway, folks, and a lot to do. And I give you this as context that we as staff know this, we as program knows this, Chair Bailey, Vice Chair Burns know this. So hopefully this is grounding for you, and that and a little bit of clarity in what is a reasonable ask of you and what the expectation is. So with all of that, as we tee up this conversation, I have one more piece for you, in that I was fortunate to attend to the National Academy of State Health Policy meeting last month in Nashville, where I was fortunate again to hear David Seltz speak. He is the director of the Massachusetts Health Policy Commission. He was speaking about affordability in healthcare, and he offered up a quote from the late, great tennis player Arthur Ashe, an health equity champion. And I want to share that with you because it's really appropriate at this time. And that Arthur Ashe said, start where you are, use what you have, and do what you can. So, board, as you take ownership of this process and this report and this plan for the legislature to consider, I'm going to quote and invoke the words of the great Arthur Ashe: start where you are, use what you have, and do what you can. So with that, Chair Bailey, I will hand this off to you with great enthusiasm as we go forward to workshop these ideas over the coming weeks.
Absolutely. Well, Ralph, thank you very much for that motivating start to help guide us through this discussion. Ralph, I can say for clarity, I was hopeful that Bobby Courtney from Myers and Southworth would be able to help kind of guide us through some of this discussion around the packet and some of the methodologies that were outlined to my colleagues. Is that in alignment with what?
Yep, and I see Bobby's got his camera on and ready to go.
Okay. Just checking to see if that worked for Bobby as well.
Yep, we're ready to roll. And I don't know, I think Melissa, and unless you disagree, Ralph or Chair Bailey, I think we can skip past these two slides and just go straight to the discussion guide document, which is the table of the UPL approaches. If you have that.
With what I was thinking, Bobby, I'm just trying to find it in the packet, but
Oh,
yeah.
no worries. Do you have that available, Melissa, that you can share?
Yes, I do. I'll get that right up.
Thank you. And so while Melissa's pulling that up, just to sort of kind of jump off from Ralph's opening remarks there, what we plan to do here is walk through several approaches that other states have leveraged when setting a UPL. These are really designed as sort of high level general concepts, tools, so to speak, that the board might wish to have in their toolbox. We've also outlined, for purposes of discussion or to get the ball rolling, some methodology considerations or implementation considerations, to drive conversation if necessary. Regarding these considerations, they are not comprehensive, really just, like I said, intended to kind of drive discussion. So I would say that actually, if you can go a couple pages in there, Melissa, till we get to table 1. There we go. Perfect. Yep. So my job here, my role here today is to really sort of help facilitate this discussion and maybe kind of play air traffic controller a little bit as we go through these various approaches. Obviously, there are a number of board staff on the call, as well as board staff consultant Jane Horvath from Horvath Health Policy, all of which are available to contribute to the discussion, support, provide additional context, answer questions, things like that. So with that, I'll kick it off by just briefly sort of describing this first approach, which is probably one of the approaches that folks would be most familiar with, which is really the net cost approach. And the idea here, and I'm not going to read everything to you all, but just to summarize, is that you would establish, or a board would establish, the UPL at or near an existing average net price for the drug after accounting for rebates, discounts negotiated, pricing concessions. So this is something that would be particularly useful for highly rebated drugs, which are generally placed on high formulary cost share tiers. As you're likely also aware, I guess the biggest, one of the biggest methodology considerations is really the sort of the type of drug, and particularly the spread price concessions among payers, the degree of discounting, some of those components that may not, from a data perspective, be easily identifiable. Probably one of the bigger methodology considerations to point out there. But with that kind of high level summary, I'll open it up to the group and ask the board to jump in with thoughts, considerations, things that they'd like us to make sure gets incorporated into the report around this particular concept. Robert.
Yeah, thanks, Bobby. So just to make sure that my head is looking at this right, this essentially would be, if we established an upper payment limit, it would be factoring in what rebates we may be able to acquire or negotiate on behalf of purchasers in Oregon? Is that the thinking here? And then
I-
build that into the upper payment limit?
Yep, I think broadly that's the 50,000 foot conceptually. I think that's the thinking for the approach.
Yeah, does that look like, I'm familiar with what Washington State did with the hepatitis C drug. Is that kind of the model that you're thinking of here?
I think, and I'll look to the Ralph and board staff to weigh in here. I mean, I think there are different approaches that you can take with this. I think when we've seen the various states with UPL authority leverage the net price approach or the net cost approach, it's a little different. So I don't know, Ralph, Chair Bailey, if you have specific thoughts around, how nuanced you would envision some.
Yeah, thank you for asking, Bobby, because I was going to ask a clarifying question to that too, and I think it might be an appropriate time to give Jane, a couple moments to kind of level set related to this, but just so that my colleagues and I are all kind of on the same page of understanding, it's my interpretation that the net cost concept is essentially the concept that was shared with board members in previous meetings, kind of related to setting a UPL essentially on the buy side. Is that in alignment with, am I understanding it the way that it's intended? That option number one, the net cost, is essentially what we've been talking about in previous meetings.
I think, Chair Bailey, if I can, I think that is accurate. I think conceptually, some of the conversation likely would be around how, and again, recognizing what I said earlier is that we're not going to be able to get into every level of detail, but I think philosophical and process kinds of conversations as to whether these should be administered through upfront discounts from the list price or whether it should be a rebate structure. I think those are the kinds of considerations and discussions that are fruitful, because that way we can hear from individual board members who come from different practice environments and different settings as to where they could see potential bumps in the road or heartburn or clear skies above, if that resonates with folks.
It does. I guess it gives us a broader framework that we can work from at a later time, is kind of what I'm hearing a little bit. But with that said, Dr. Hartung, I see you have your hand up, so you have the floor.
Yeah, so I don't know if I'm supposed to constrain my comments to this specific domain of the table, but
I think the plan was to kind of move through each of these approaches or concepts in turn. But I think if there's a connection or that you think is certainly worth pointing out, I mean, obviously I would say jump in.
Oh, okay. Well, one thing, and I think this is just flagged at some point in some of the other material I read in the packet about establishing an upper payment limit that based on net price from, if we looked at across all payers or a subset of payers and the rebates that they're able to get, if that, if the upper payment limit was tied to like Medicaid rebate, for instance, or if it undercut the Medicaid rebate, would we run into issues in terms of establishing new best prices for the Medicaid program, or how to navigate kind of that whole issue, and knowing that, Medicaid often is able to, garner pretty substantial rebates, and if our upper payment limit, was based on that or lower than that, what consequences that would have.
So is that something, Ralph, that you want to weigh in on, or Jane? Would that be a good opportunity to describe, I think, just generally speaking, the best price implications for these?
Yeah, go ahead, Jane. And I do not know if we have Jane promoted to speaker present, but as Melissa brings her online, I think, Dan, what I would say is that those are things that as staff and program we are certainly aware of, and that, again, not knowing it's hard to have a conversation about any given drug without talking about any given drug and what a net price could be, or a potential discount scenario or rebate applied could be to get to a net price. But conceptually, yes, I think we would flag that as a caution and warning in the report, if that's where you're going, that anything that could conceivably butt up against or set up a new best price could create legal challenges unto itself. Is that where you're going?
Well, yes, and then also, could we just, could we think about in terms of, thinking about the Medicaid rebate and use that as in some sense, a yardstick for, applying that Medicaid rebate to kind of as help us triangulate what the upper payment limit would be for a particular drug.
So I would say the answer is yes, but ultimately putting that back on you as a collective board to make that decision. But let's invite Jane. I think we've got her promoted.
Yes, Ralph. Jane, you do have co-host permission, so you should be able to use your camera and mic now.
Jane, it looks like we can see about half of you. And we can see you raising your hand, but no audio. All right. Staff and Chair Bailey, if we can get Jane's audio figured out, we can circle back with her, but let's try to keep the conversation moving in the interest of time. Bobby, if you want to continue.
Sure. Other board comments, questions for staff on the net cost approach? Methodology considerations, concerns. John.
Thank you, Bobby. I guess I have always been wary of rebates and how they work their way through the healthcare delivery system, drug delivery system, especially where we don't know where a lot of that information is. And we've actually had stakeholders that have testified or reported in our prior meetings that, rebates is only one form of money or describing fees within the drug delivery system. So I guess I would be wary. I guess I'm worried about rebates in the system at all, because as someone that's at the end of the food chain, as I've commented before, we are always at wonderment of how prices came to us the way they did, and how support for plan sponsors, for example, that get the majority of rebate, for example, or where all the profits go for these extremely high cost drugs. $500 or $600 for a new coagulation med, anticoagulation med every month is really hard for people to afford where I live. And so however we can get to something that's more meaningful, that we can get to a cost that makes that we can actually see. I know the information that's coming in, and we hopefully have a presentation coming up on the PBM rebate information that's being reported to the state now. Great. I'm worried. Let me just say that, I guess, of the reliability of the data.
So thank you, John. So just to do a bit of a listen check and maybe carry this conversation forward just a little bit, that preference, and invited board members to weigh in, but preference for a conceptual model would be leaning against a rebate structure for both data integrity and administrative burden reasons, presumptively. I guess to do a listen check there, and then that I think we hit this later in conversation and discussion, but jumping ahead, that if a upper payment limit model was also to require PBMs to pay pharmacies no less than the upper payment limit, that too would provisionally or conditionally be based on an upfront price and not a rebate model? And John, maybe if I could ask you to speak, you might be best positioned to speak to some of the hurdles and administrative challenges that pharmacies may have in working with other vendors to implement the Medicare fair price numbers, and if that is a cautionary tale for what a potential feature of a UPL program should look like here.
Yes, I may not be the best to address this.
Okay.
We've had other people that probably speak better to it. I apologize, but as one price that works through the drug delivery system, and it ends up, I can speak to a pharmacy, you know, how do I, as a pharmacist and an independent pharmacy, keep my doors open where I have to have something to end the day with, to pay my staff with? And so I'm sorry, I don't have all the details of rebates and how it works through with the wholesaler and how those contracts work in detail. I need to work on that. I apologize.
Mr. Judge, you have the floor.
Yeah, just maybe just add around that. So really, when we think about cost of drugs going through the supply chain, we have to think about the sell side and the buy side. And, you know, John and pharmacists represent kind of the buy side, right? They buy the drugs and then they dispense the drugs, they get reimbursed for those drugs. And then there's this sell side, which is really what manufacturers are willing to kind of ultimately net price that drug out for to the payer, which is, you know, I think there's a lot of discussion going on whether the payers, you know, self-insured employer group or an insurer, or whether it's the PBM and being compensated for the work that they're doing. But ultimately, manufacturers control what they're going to give up on that side as a net price paid. So when we think about a net cost model, the first thing we got to think about is do no harm. And so the thing that worries me about this is potentially having a price that's paid net from a manufacturer that harms and damages pharmacies, right? So that their acquisition cost is higher than that price is out there. So there's got to be consideration to the supply side. Pharmacies do an outstanding job. There's a lot of discussion and consideration about whether they're adequately compensated on the dispense fee side when they, you know, today that model works on drug price reimbursement and dispense fees. But if the price is already set, then you've got to make sure that pharmacies aren't harmed and that they're paid professionally. And then on the payer side, ultimately, since they're paying the bill for the drug, the net cost has to result in a way that kind of supports an upper payment methodology. I'm comfortable with rebate models doing that, provided they do no damage to the pharmacy.
Well, and Robert, I think you bring up a kind of, you're alluding to a really good point that I guess is further down in what Bobby's going to share, but this conversation of kind of net upfront versus rebate, from my perspective, is one of the is a key thing that as a, you know, board that we really do have to have kind of comprehensive discussion on. I don't know if we have the flexibility in our report to kind of say we want to be able to get to net costs in multiple ways that may involve different processes on different drugs, if some are highly rebatable and some aren't. But this is, I think, one of the key discussion points that as a board, you know, we need to be diving into today as colleagues.
I do see, I think we have Jane promoted, but to that point, Chair Bailey, I would flag, and again, in the construct of this will, if getting there in due time, this would be a multi-pronged approach. And to Chair Bailey's point that what's cited here around net cost is this is particularly useful for highly rebated drugs, which are generally placed on a high formulary cost share tier. So perhaps the discussion, maybe with the broad representation we have of folks here on this board, of when would this be appropriate versus drugs with lower cost and lower rebates? How might this scenario fit uniquely to some drugs, whereas it might not work for others? I mean, is there consensus that, and Robert, I'll go ahead, but perhaps maybe a question, is there consensus or feelings amongst the board that this would be a preferred approach for drugs that are highly rebated, that are generally placed? Now there we go. We're getting hands up. All right. Would this be the most appropriate approach for drugs that are highly rebated, which are generally placed on higher cost share tiers? And we can workshop this with both Robert and Dan.
I'll just say this: the rebate model is people have strong opinions about it, but the market is built around rebates. So that infrastructure, that capability, that process methodology works. Whether it's a Medicaid drug rebate program administered by fee-for-service Medicaid, which has lots of checks and balances in it, or whether it's a PBM administrative rebate program directly with the manufacturer, the methodologies work for that. I'm comfortable with that model. I'm less comfortable with the net cost up front since I do not know how it would make its way through the supply chain.
Great, thank you. Dan?
Yeah, I guess I'm talking less about the mechanism of implementing the UPL either through rebate or just through this setting the upper payment limit. But in terms of drugs that are not highly rebated, there is generally there's drugs where there's a lot of competition in those classes, and so I think that I don't know if we're saying that we should focus the UPL discussion on those drugs that are high list but also have extensive rebates makes sense, because I think that there needs to be focus on those drugs where there isn't competition driving those the high rebates. Yeah, so that's just going. I just wanted to.
Yeah. So no, I think that's where we're looking to head with this conversation, Dan. So to that point, which of the other approaches would be the most prudent in your mind in those situations?
I like a mix of them. So when you have classes of drugs where you're not seeing a lot of rebates because of competition, or maybe there's like just great heterogeneity in the classes and they're not competing on efficacy, or there's just a lot of differences that they don't need to compete on price. Looking at other established systems, the MFP I feel like makes a lot of sense, using that as like a yardstick for figuring out what upper payment limit might be, as well as negotiated prices from VA. I think that makes a lot of sense as well. I'm less enthusiastic about kind of these international pricing comparisons, because I feel like you run into more complicating factors, but certainly staying domestic and looking at how other large integrated healthcare systems are negotiating prices, makes a lot of logical sense to me.
That's very helpful. So, I mean, Dan, could you conceptually see in some of these situations possibly the either a percentage off WAC discount being appropriate methodology, or relative to other therapeutic alternatives? I mean, can you offer a little more commentary there on how you might approach those?
Yeah, I think my response was going to fall in lines with it really depends on the drug and the drug class type of individualized approach. The percent of WAC just seems too much like a meat-axe approach, too non-specific. But looking at it at a case-by-case basis, and then again looking at what other systems have done in those cases, I think, and looking at the diversity of other therapeutic alternatives in the class makes sense. I think about in one of our earlier discussions with portal folks and Dr. Rome talking about, the new anticoagulants and whether or not it's relevant to compare it to warfarin, which is, costs pennies a day and, is comparable efficacy, although, and I think it's less effective, but, it's just kind of on the margins, I would say. Yeah, I think a mix of approaches is and it's going to have to differ, but based on the disease state and the drugs that we look at is kind of where I'm starting to drift.
I think that's great. Before we go to Dr. Burns, do you think, or could you conceptually see, and thinking out loud with you here, could you conceptually see value in using this kind of approach list, if you will, for a market basket and say, I think that for this drug, X approach might make sense. For that drug, Y approach might make sense. And where I'm going there is that even stripping out the list of drugs at the end, the net work product would be a bit of a map that when you find certain drugs in certain situations or scenarios or classes that, again, we're not going to get so specific and boxed in with any one approach, that exercise could help tease out the details into some of the points that I think John Murray made earlier, some of the challenges and concerns around different approaches. Would that be a fruitful exercise?
Yeah, I think I lost the thread on kind of what you're describing.
Sure.
I'm a little
Would
sorry.
it be, that's okay. Would it be a useful exercise to look at a market basket of drugs and go through this kind of list and exercise and say, well, hypothetically for this drug, I might lean towards approach one, or hypothetically, I might lean towards a different approach?
Yeah. I mean, I think practice going through
Okay.
this activity, I think would be fruitful. And when we have, plenty of potential options out there that we may not ultimately make a decision on, but would be good to help kind of get our feet wet with the
Great.
process.
Well, we will work towards that. And Vice Chair Burns.
Yeah, that's kind of what I'm trying to get at. What's the exercise here? Are we looking to eliminate some of these approaches and like pick a favorite approach, or is it what you're suggesting? Like we have all of it's a board and we get to pick, depending on the drug that we're looking at, which approach we want to go with. Like I'm trying to get at where we're going here.
Sure. I think the answer is yes to all of the above, and ultimately to really conflate things for you. No, in that I don't believe that the intent of this exercise that we've prepared and worked with the contractor for is for you to disqualify or eliminate approaches. And I say that based on what I said earlier and reference some of the work that's going on in Maryland, and that there is not going to be a one size fits all approach to all of this. So I think to that point, if there are observations that could be made, and I think I'd consider this to be implementation considerations, drug with a narrow therapeutic index or limited, FDA indication that is clearly best in class. That's a different conversation entirely than a one of many where there are lots of therapeutic alternatives. Overlay the different rebate scenarios that we talked about. So I would really discourage you from eliminating any of these. And to that point, I would say the same thing if anything in here where you were to see and have concern about the legal viability of any of these things. We know, and all of us know, that all in due time, many of these approaches and these challenges will be pressure tested in court anyway. So that I say this out loud to you because I do not want that to be a discouraging or rate limiting factor in you all having the courage to go forward and make good progressive public policy if that's what you think is appropriate. So
just so I understand, so everything is on the table because that's what I got from your speech at the beginning, your motivating speech. and then, so we're just kind of looking through it and trying to pick out where we think it might. If everything's on the table, I'm just confused because it feels like we're working towards like pick me sort of situation. So,
But picking could be C or D or F or G, all of the above is what I'm saying. And that
depending on the drug.
depending on the drug and the situation and scenario. And again,
Okay.
that's why that's what makes this a challenging exercise. So if in the end, and I think we'll go to Robert and then John in just a sec, but if in the end this deliverable to the legislature says, and I say very concisely in the interest of time, there is no one size fits all approach to upper payment limits. We believe it will be dependent on any given drug identified based on XYZ criteria. Here is a list of options that the board would need to consider, implement, or evaluate prior to determining what the appropriate UPL strategy could be. That's okay. Because again, as noted by our friends at Pharma and others who have commented, there will be a long runway of decision points and rulemaking ahead with this if granted this legal authority to do this. So,
Okay, thank you. I appreciate
Sure.
the clarification.
Yep, absolutely.
A number of hands up, Ralph. I just wanted to do a time check. I know you wanted to get through quite a bit of this today, and I think we're, at least in terms of agenda, probably just under 20 minutes. I think you had allotted for this.
Okay, let's do, I'm glad that we are getting engagement, so let's roll with this and go with the folks. And I think Dan had his hand up at one point earlier too, but if I can, John and Robert, let's go to Dan first and let's keep going with this since we haven't heard from him yet. Dan Kennedy, go ahead.
Oh. Thanks, Ralph. I was not sure which Dan you were.
Oh, my bad. Sorry about that. Fair question.
So I am in agreement with you. I agree that there's not any one size fits all. And I would benefit greatly from having an exercise where we just look at different drug classes and different methodologies and try and figure out which would work best for which scenario. So I just wanted to say that.
Great, thank you. And let's do John, Murray, and then Robert.
And Dan's comment was pretty much exactly what I was going to ask. Is there a chance that we could take one drug and work through each of these different concepts or just and see how they shake out? We may find that 2 or 3 of them work great and it gives us options, and 2 or 3 don't work and give us off the charts results. It would be helpful for me to see how one drug, the same drug, works through these different pricing things, concepts, please.
Sure. So I think the answer is yes. We're going to try to make that happen as staff for you as soon as possible. With that, I will disclaim that I will need to check on what our public notice obligations and requirements are in context that we'll be meeting again 2 weeks from today. And in fact, I think I've just posted that agenda. So I will certainly look into the ability for us to do that in 2 weeks, both from a staff resource time commitment to be able to put that together and make sure that we meet public notice requirements. And if not, we will figure out how to make that happen as soon as possible. Robert.
I'm going along the same path here. I think it's easier to eliminate some than to, but I do think the model of trying to take the drug or drugs and work them through the scenarios probably be the most instructive, with the one suggestion that when we look at this and we model it out, we need to look at it from both supply side and payer side.
Great, thank you. And Chair Bailey, back to you.
Oh, no, absolutely. I was just going to make a comment. I agree with the comments all my colleagues have said. I do want to be careful that if we're going to do an exercise, I'm a little hesitant to pick one drug, because I think maybe it's appropriate that we could like pick a class or something. I guess I would be cause for pause to pull one drug without kind of a broader discussion about what that drug might be. So I just want to mention that would be a one hesitation I would But I think Dan, your hand was up. Dan, Dr. Hartung, sorry. So
And Dan, you're on mute.
Sorry. The other thing I wanted just to note is that now that I'm kind of hearing the dialogue and kind of re-evaluating or looking at this table, it's great. It's a great table, and it's a great summary of the different approaches to think about upper payment limit, but also it keeps creeping back is the implementation side of it. And like, I assume that's part and parcel with this as well, is like, you know, we can set the price, but how it's actually implemented. I know that's a lot of the uncertainty and danger there to pharmacies and to whoever gets you know, held with the drug at an unfortunate price or whatever. And so and that part of the equation is quite opaque to me. So I don't know if that's a separate dialogue, the implementation phase of it, or because certainly I think it's even perhaps a little more clear cut to thinking about the payment limits and then figuring out, okay, how is this actually going to be implemented? Because they're related but distinctly different.
So they absolutely are related. I do want to just make one statement, because I know that in what you just said, there were several references to setting price. And for the record, I do just want to state that upper payment limits are in fact payment limits. They are not price setting by either the state or any other part of the supply chain in Oregon. But to that point, Dan, I think the question or issue is, and this is the tension of needing to develop substantial implementation recommendations that take into consideration the same challenges that you're talking about right now. So sufficient meat on the bones, if you will, but knowing that it is not going to be something that is fully built out, because candidly, it just can't be for all the reasons that we've discussed.
I do want to mention that I saw Chris previously had his hand up. I want to make sure that you have an opportunity to share your thoughts related to this discussion.
Yeah, Chair Bailey, I think the notes that I've just scribbled down are similar to what John Murray and Dr. Hartung said. It was just really the implementation phase, and wanted to make sure if we're going to do that walkthrough process and say, hey, it's going to be a rebate based on net cost, like that model, how does that affect the pharmacies? How does that affect the FQHCs that we heard from in our, you know, listening sessions, who are relying on the 340B, you know, revenue that's coming in, or savings that's coming in the door to support their program. So I was going to ask if that was going to be part of the walkthrough, and it sounds like not maybe to the working it all out, but at least it would be thought about or discussed.
Yes, Chris, it definitely it is a part of this discussion, and has to be. Absolutely, positively it will. But to the point of this rebate conversation, I mean, I do want to note for folks that, and I think it is electronic pages 29 and 30, it is numeric pages, I think 8 and 9 on that other document. But we've provided, through the work with Myers and Jane as our consultant, quite a bit of commentary and policy analysis on potential market segmented rebates and upper payment limit implementation. I know we don't have a heck of a lot of time, but with that said, if we do have Jane teed up and her audio issue is resolved, let me invite her just to speak to that for a minute if she's so inclined.
Sure. Hi, sorry for the complications earlier. Can you hear me?
Yes.
Okay, good. So about the rebate versus through the supply chain, is that the question, Ralph?
Yes.
Yes. So if it comes through the supply chain from the manufacturer to the wholesaler, then it would just be distributed in the state of Oregon as any product is. Now, You could decide maybe to use a dedicated wholesaler, or all wholesalers who can procure the product at or below the upper payment limit from the manufacturer. And you might want to look at dedicated wholesalers for specialty drugs, very low volume drugs, other things like that. So there is a range. So, but that's the supply chain. And then the rebate would be that the product would come in at market and be vended at market from pharmacies potentially. And I'm not sure how the payer IT systems through the pharmacy would help to get that, the patient copay or cost sharing based on the UPL, or if the patient is going to, if their cost sharing is based on market. If you can, how would you get that lower cost to the patient at the pharmacy counter using rebates? That would be sort of the big question. But otherwise it would go through the payer just as it normally does. But that interaction at the point of service is sort of the big question with a rebate model.
So I know Dan Kennedy and Robert both have their hands up. Let me pause for a second if I can look to Chair Bailey and I think Courtney and Melissa for a little clock management check-in in terms of making sure that we have ample time for additional conversation. Courtney and Shelley, how much longer are we able to run this segment?
I can shorten the recommendation conversation down to about 10 minutes, I think, is what we had like 20 on the agenda, and we can just do a high level review since this is an initiation of a discussion.
Okay, so if
I
we
think this is
run,
more fruitful and more meaningful than the recommendation, and we can touch base on
Okay.
that more at the next meeting.
so if we run till 11:25 on this, we're good?
Yeah, even 11:30, I think.
Okay.
Yeah. Robert, I see your hand is raised. We cannot hear you if you were intending to speak.
Yeah, I kept on muting myself. Just to comment on Jane's reference on the wholesaler route and pharmacy, and then how do you handle patients from a copay perspective. On the wholesaler side, I totally get the drug coming from the manufacturer to a wholesaler at maybe some established upper payment limit. The presumption would be then, Jane, that I guess that pharmacy would be able to purchase that drug at that upper payment limit price. So the value could make its way out to patients and payers. Is that kind of how you're thinking of it? That's question one. Yeah.
Yes. So in other words, it would actually probably come in at less than the UPL as it comes in less than WAC.
Yeah.
And everybody,
Yeah.
you know, it goes through the process. So it
Right.
would be that same mechanism. That
Great,
same
okay.
approach.
And then if it went the rebate route, I'm pretty confident that payers and benefit designs, as long as they have a price that's known, a net price that's known, they can price that out in their patient copays and coinsurance rates. So it wouldn't be, there's a way to pass that through as long as that is known. They could factor that in.
I think to your point, Robert, I mean, from my perspective, you obviously have a lot more payer experience than I do, but I mean, I think there's a mechanism for that now, even with some of the things that are going on with insulin and things. One of the issues I want to shine light on related to the buy side in pharmacies, and this is related to access, of course, is if there was a single wholesaler and things that impacts bulk purchasing contract negotiations. And so I can envision that the buy side of this could get very complicated very fast. So that's just kind of one comment I have related to spending 20 years in pharmacy. And Chris, I see you have your
and just managing a whole separate wholesaler and the order points and everything that you have in your electronic system, right, Chair Bailey? I mean, it would be painful for the pharmacies to, or at least for my pharmacies, to have a whole separate wholesaler just for these drugs.
Yep. Yep.
And that is something that I've heard in previous feedback too. And then again, just my personal experience, just like the rest of your personal experience, I do think that's something that would really have to be more thoroughly discussed. But we could maybe, have the flexibility for those discussions, but I did want to bring that to light.
And if I can, Chair Bailey and Chris, I just want to thank you for chiming in there. These are the exact kinds of operational issues, challenges, and concerns that we hope to capture through this exercise, because we're not going to figure out a pathway forward unless we do. So again, just thank you for sharing those things, and to the rest of the board with the real world knowledge out there of how a lot of these things works. We implore upon you to share these issues with us. So.
Yeah, Dr. Hartung, I believe your hand is raised.
Yeah, thanks. To that point about the multiple wholesalers, do we have any insights about how this maximum or Medicare maximum fair price is going to be distilled throughout the supply chain? Is it, are they going to have a separate wholesaler that pharmacies are going to have to purchase from for these, at this maximum fair price, and then sell exclusively to Medicare beneficiaries, or how do we know how that's all shaking out?
I have a peripheral understanding, and I think John may be best positioned to answer if he's comfortable from that, although he disclaimed that I don't think he has a full understanding, and candidly, lots of folks are probably still trying to figure it out. It looks like Alan Hansen from Myers may have. Alan, is that something you're able to speak to quickly? While Melissa tries to promote Alan.
And we will, yeah, sure. Alan is part of the
Yep.
marketing staff for his team, so we want to.
Hi, Ralph. My understanding is that for the Medicare maximum fair prices, that they're proposing to use a model that would create an entity known as the Medicare Transaction Facilitator that would, for transactions that occur between a Part D plan, PBM, and a pharmacy at the maximum fair price, there would be a mechanism through the Medicare Transaction Facilitator to make the pharmacy or other dispensing entity whole with a payment routed through the transaction facilitator, with eventually that chargeback going to the manufacturer. I'm not sure that there's all of the details for that have been worked out yet, though.
Thanks, Alan.
Sure.
And Jane, did you have something? I know we want to keep moving, but was there?
I just wanted to say that in the MFP scenario, the drug is going to be in the marketplace at the market price. So pharmacies buy it at market, they bill at the MFP. So they bill the patient for the copay or co-insurance based on the MFP, not what they purchased it for. And they bill the Medicare D plan at the MFP. And then that facilitative process that was just mentioned by Alan is that's making the pharmacist whole, because the pharmacist bought it at market and dispensed it at a lower MFP. So that's that critical junction. And it looks like that because the market is segmented. Not everybody is in a Medicare. Not everybody's Medicare eligible or enrolled.
No. Way too complicated.
Robert, it looks like, or Bobby, do you have something you want to add before?
Robert, no, please go. I wanted to ask a question, being mindful of time and thinking about sort of next steps for the report, but Robert, please go.
I'm probably speaking out of turn, but I would think that every pharmacist would react to what you just said, Jane, that's a time value of money issue. They've got to lay out cash before they get some refund from Medicare at some point in the future.
Yeah.
That's a difficult.
That ain't gonna work.
Swallow.
Oops, Ralph, you're on mute.
Thanks, Bobby. To that point, Robert, I would just say this is the importance and part of this exercise. As I said earlier, it's as much, but by learning about what doesn't work, it shrinks the pool to figure out what does. So this is the spirit and intent of this conversation. Can we go to John Murray, and then Bobby will ask you to do a little wrap up, and we can talk next steps.
Yeah, Ralph, you mentioned earlier, you asked me for input on the pharmacy and the day-to-day operations of the pharmacy and our negotiating for the best price we can get on our medications. The more complicated that it gets, the more difficult it is for pharmacies. If we have to wait any length of time for settlements to be whole through a UPL process, however that's determined, I think it's going to be a challenge for pharmacies. As we're going to points I'm going to make further on when we discuss recommendations, pharmacies are pushed to the max right now already. And so as far as profitability and having the lowest access to pharmacy, well, second lowest in the state of, in the nation, second only to Alaska for access to pharmacies by patients, we need to be careful that we don't impact pharmacies negatively and their ability that's already teetering on failure to stay in business, please.
Yep, we hear you. Thank you. All right, Bobby.
Yep. So again, just wanting to be mindful of time. I know, Courtney, I think you said we had till maybe 2:30. Thinking about next steps, it sounds like, and I certainly don't want to put words in folks' mouths, but it sounds like, the way Ralph had sort of described this as these are approaches that the board might consider. I mean, it sounds like that's the direction that, collectively these various approaches would maybe be in. My question to the group while we have everyone, is there anything that we've talked about or that's on this, kind of high level table? Is there anything that would be off the table? Because I think, I heard one comment, perhaps from Dr. Hertog about, the using international reference prices would be something that I think you had said would not, that wouldn't work for you necessarily. Are there other things in here that should be noted as riskier or, that folks aren't necessarily supportive of?
I just want to quickly amend my comment. I'm not totally opposed to it, but just on the cough, it struck me as not as a lower tier thing, but so just that's it.
Not necessarily excluded from an option, but maybe not something that you'd lean into sort of as, you decided to sort of apply these various approaches.
Yeah.
Robert?
Yeah, there are three that just to me, I really struggle with. The first is probably going to be the most unpopular to say, but the 340B option, I understand that they capture spread and that's used to fund the safety net. There's no explicit language in HRSA's rule that mandates that. It's more of a practice that they've allowed to happen. So I struggle with that as an option. I think the launch price indexing could lead to high launch prices, which might be an unintended consequence. And the percentage of WAC, I believe, is a price lock-in that might hurt us over time.
Dr. Burns?
Yeah, I would kind of agree with Robert on the 340B option. I don't know how helpful that would be as an option when we're talking about kind of like the state as a whole and all all aspects of the system and consumers. I think that the budget impact based is an interesting concept. I don't know how well that's going to work within like the list of drugs that we've been looking at. I don't know if I would take that off the table, but I'm not sure that that's really going to get where we need. So I guess those were the two that kind of called out to me that were, if we were going to get, take something off the table. But again, I'm not opposed to leaving things on the table.
Sure, and part of my rationale for asking is as we help the board staff kind of prepare the some draft report language for you all to review. I want to make sure that we're framing these that your thoughts and your what you're expressing appropriately. So.
And Bobby, I think Dr. Hartung, sorry, get my Dan's mixed up here, had his hand up for just a quick sec. Can we see if Dan wanted to chime back in with something?
No, sorry, that was an accident.
That's okay. No problem. So, Bobby, I think generally speaking, we've gotten a lot of great input and feedback from board, and I think collectively staff will work with you over the next week and two to shape this based on some of the things we've heard in terms of priorities, weighting what may work, what doesn't work. I will explore offline what our ability is to meet notice requirements and still try to do some sort of exercise with a small sample market basket, and we will go from there. So I appreciate everyone's collective thoughts. And Chris, what you got?
Yeah, I just had a quick, I want to support what Chair Bailey said earlier, that I don't think that the optics of us picking a drug and walking through it with one particular drug is the best idea. If there was a different way to do it but still go through the exercise, I think it would be better.
Sure. And quick opportunity for folks to make an alternate proposal on that would still help with the prioritization of approach exercise. If any of you have thoughts or ideas, we are wide open to hearing them.
I'm in agreement with that.
Let's see, Dr. Hartung, you go first, and then I'll make a proposed suggestion.
Oh, just like one kind of thought that just crossed my mind when you mentioned that, Chris, was that perhaps staff could go through the process with a drug or a class of drugs and just only present, kind of de-identify it for, leave the dollars and cents there, but just de-identify the drugs themselves, I guess, would be one way to maybe avoid that simple solution. I don't know if it's foolproof, but popping in my head.
Dan, you were reading my mind. I was going to try to suggest something similar. I did want to also lean into something I believe I heard Robert Judge say, though, was if we are going to attempt this exercise, I don't, again, know the timeliness for which meeting we can achieve this, but I've heard Robert say a couple times, both buy side and sell side. So we do want to make sure we're trying to take into consideration as many of the stakeholders in the, kind of the delivery chain. Many of those are ones that we have had constituent meetings with in the past, but I just didn't want to lose sight of Robert's previous comment about balancing both sides.
Nope, that's great. And Chair Bailey, we will work with staff and see what we're able to do and potentially pull something de-identified together, and we'll work with you offline over the next week or so and see what we can do. Thank you.
Absolutely. Well, related to timing then, I guess we are moving forward with our policy recommendation piece. Is that accurate, Ralph? Okay, well then each year the board provides policy recommendations to the Oregon Legislature. Today, the board will discuss proposed policy recommendations for 2024. I call on Courtney Whitlock, Senior Policy Analyst, to help get us started related to this conversation. Courtney, you have the floor.
Great. Thank you, Chair Bailey. Appreciate the opportunity to speak with the board about the upcoming policy recommendations. I provided each of you the recommendations to review. Again, today's is a discussion. No decisions will be made at this time. We will make the decisions on which to remove or implement at our next board meeting in a couple of weeks. But just as a high level, some potential concepts is to clean up some items under Senate Bill 844, which is our governing statutory requirement. Some of the language suggestions would be to alter the language identifying the 9 drugs each year, and change the language to suggest up to 9 drugs a year. As we identified through the first iteration of the affordability review, identifying 9 drugs was very much a challenge. Not just because of the data sourcing and information, but it is challenging to identify 9 specific drugs that could be affordability challenges through the criteria and rules that we've developed. So kind of changing that up to identify up to 9 will be beneficial, that we capture at least a handful, but not always at 9. So just as a suggestion. A second proposal would be to remove requirements that Department of Consumer and Business Services, or DCBS, provide PDAB with a list of prescription drugs each calendar quarter. So we have not, this is regarding primarily the manufacturer reporting. The statute requires that DCBS, or the Drug Price Transparency Program, submit to us each quarter drugs that are submitted that have had price changing in them. One of the challenges with that is that that is only for the current year of review, and our statutory requirement is to review drugs from the previous year. So we have drugs that we're reviewing for manufacturers, but really we can't do anything. We can't apply it to the year previous because of the gap in timing. So it's not truly a meaningful one at this time. However, we can still collect that information from the manufacturer, or from DPT from the manufacturers, to apply in the year of drugs being reviewed. Look at any of those drugs during that time instead of doing it in a quarterly breakout, when really there's not much of a meaningful purpose behind that. The third recommendation would be to remove the generic drug report annual requirements. So we have had 3 publications of the generic drug report. There has been some challenges in getting enough information to apply, since there's not much changes in the generic drug market. However, any information that has been meaningful in the generic drug report would be applied into our annual review report. So it'd just be an additional section on top of the price trends, all the drugs reviewed for the year, and then any of our policy recommendations. So it'd be just kind of put into a different section to remove the requirements of the generic drug report. So before I go on to the additional recommendations, was there any feedback or comments for this section? Yeah, Robert.
Yeah, I mean, I think these 3 recommendations on cleanup make sense, but I do have a question, or maybe a comment on the second one, which is the removing the quarterly reporting. One of the things I've struggled with a bit is that, we have DPT collecting information, but the board never really, the board doesn't really use it in depth. So I'm wondering if while we're making this recommendation to kind of clean up the timing around the reporting language, if there's a way to have data and reporting collected by the Drug Price Transparency Group, making that a required data element that would be provided to PDAB to use in its evaluations, to tighten that linkage between DPT and PDAB, so that DPT is supplying information to PDAB to help us in our deliberations.
Yeah, so we do get all of our information from DPT. They're the ones that supply. This is the manufacturer reporting, and then this is under the carrier reporting. The insulin list we get through the all payers, all claim. So we do get the information through PDAB, but right here, each calendar quarter, those primarily for these drugs under the manufacturers, that's what's creating. Again, if our statutory requirement is to look at drugs from the previous calendar year, but all the drugs under this requirement is coming for the current year, there's not a match for a review. So it's just removing the yearly, quarterly, but still looking at this, the manufacturer drug in comparison to the current year under review. That's what the recommendation is.
Yeah, and maybe I'm not saying it right. I get that. Right now, staff is using DPT, APAC, wherever you can get data, you're using data. And I'm wondering if there's a way to enhance DPT's service levels, what they collect, how we use it to do our deliberations. Just so we can have a single source of data in this state for information.
And yeah, and so again, some of it is already is more of an annual reporting, not necessarily just the quarterly reporting. So we have to make sure, and then whatever their staff load can hold too. I mean, they're a small team, and so there are, I think, policy recommendations that we have, such as down here, where it would be, you know, maybe we're reporting to regarding PAP, you know, PBM, they just started the PBM, stuff like that. So they do have more data that they will be feeding into us, or that could be a recommendation to feed into. So is that kind of what you're looking at too?
Yeah, yeah, I think it's a really valuable department that's set up and could service us in a very rich way if we continue to kind of make it more robust.
Sounds good.
Yeah.
What else regarding 844 policy before I go on to the others? All right, not seeing any, then additional recommendations that we can put forth. Again, is patient assistant programs reporting to the Drug Price Transparency Department. So basically this would expand current PAP requirements to include manufacturer coupons and any other payment that reduces patient out-of-pocket costs. The board can recommend that manufacturers be required to report on all patient assistance programs that they maintain or fund, since there's no current consistency in that reporting. Another recommendation is, again, PBM and insurer reporting on any copay accumulators or maximizers. This would help to ensure equitable access to essential medications and prioritize transparency, kind of like what Robert was just indicating. Another one would be to uniform reimbursement rates for criteria or critical access pharmacies or CAPS. This applies to all PBM CAPS contracts, with those listed for uniform reimbursement rates and non-discriminatory reimbursements. And two other ones would be to consolidate Appropriate Act, or the CAA, disclosures about reimbursement fees and employer plans for brokers. And then also maximize dispensing fees across all payers. OHP, FFS, or the fee-for-service and CCO purchasing through statewide purchasing groups. So statewide purchasing groups would have better pricing and terms for goods and services. And then the statewide preferred drug list, or the PDL, be implemented across the Oregon Health Plan for fee-for-service. And what it would do is there's some classes that are already covered, but the recommendation would to include all classes. So Robert, do you still have your hand up? Do you have any comments, or did you want me to call on Vice Chair Burns?
I hadn't put my hand up yet, but I do have comments.
Okay, why don't we go with Amy first? And
Yeah.
then we'll back to you.
Yeah, hi. So I think that the recommendations to expand reporting are good. I mean, the more information that we can have, the better. And these are things that are kind of opaque. And so the first two things, I think, make a lot of sense. I'm struggling a little bit with some of these other recommendations because I'm not exactly sure how they fit into our mandate for prescription drug affordability. I'll start with the uniform reimbursement for CAPS, which, I think that's, so that's the third one. I think that this is a nice idea. I'm not sure how we would implement it. And I'm not sure how it would say, like, where it falls into prescription drug affordability. Like, where is that? Where's the affordability part is my question. I don't know if you have thoughts on that.
I do not have thoughts on that, but I mean, welcome to hear anything from any other board members on that process.
Mr. Murray, you raised your hand. Was it related to that?
Yeah, it is. Yeah, if 844 was enacted to protect the residents of the state of Oregon and the drug delivery system, including healthcare practitioners and pharmacies, it's been shown, even with the Secretary of State's audit and the three-axis supply study here and in Washington State, that pharmacies are struggling to stay open, and they're closing at a more rapid rate than they're opening. I think that equity and access for some of our most vulnerable patients, when it boils down to not being able to afford to stay open, these pharmacies, this is critical to maintaining equity and access for all patients in the state of Oregon, whether they're rural or downtown Portland, it doesn't matter.
Okay.
Reimbursement rates are not
So
sufficient.
I would say, John, that this would be really, really hard to implement. I'm not even sure if it's possible. And there's something kind of similar down here with the minimum dispensing fees across all payers, which if you read the bullet point underneath it, is actually a minimum reimbursement for all prescriptions, which are two different things. So my suggestion would be a much more, I think, an easier way to get at what you're trying to express there, and to perhaps address that part of the system that is definitely a pain point, and is hurting and is being squeezed, is looking at dispensing fees, because you're tying together, or not you, but these two recommendations are tying together reimbursement and fees. I think trying to get like maybe a strict dispensing fee, or a dispensing fee minimum where it could be uniform would be a much easier and more effective way for a recommendation to get to the legislature to try and address the situations that you're expressing here. I think that the idea that that the entire pharmacy system, so all of these different payers, would be able to reimburse at what fee for service is reimbursing for caps, and then down here for the AAC pricing that's put in place. I don't know that that's even possible. I don't know that that's could work. And quite honestly, in some cases, I think it would cost the system a lot of money. So we might, help with independent pharmacies and kind of address the landscape that you're talking about, but cost the system a ton of money. So I guess my suggestion would be we think about maybe taking some of this and combining it and trying to address an aspect of it that would be surmountable.
Dr. Burns, for that feedback. And I think that's something that I can work on until we meet in a couple weeks, kind of clean that up. I do want to be mindful of time. So if you have some quick comments just for feedback for me to clean up for next meeting, I will take those real quick. Otherwise we'll continue the conversation next week, because I know we have 3 people that want to talk today in public comments, and I want to give them enough time.
Yeah, Courtney, let's create space for, this is important. We'll make sure that we get time for commenters, but let's make sure that we have opportunity to hear from Dan Kennedy and Robert on this, and then we can close out.
Yeah, this is Dan talking. Yeah, while I don't disagree with what Amy said, one point of notification is not just independent pharmacy that's having difficulty, it's pharmacy that's having difficulty, whether that be health system pharmacy, community retail pharmacy, all of pharmacy is having a problem. So setting a minimum dispensing fee is really paramount to ensuring that residents of the state have adequate access to pharmacy services. So that's all I wanted to say.
Yep. So Dan, totally appreciate that and respect that. And we're going to go to Robert and then we'll ask Chair Bailey to close us out. But I do want to state for folks, because it is important to level set that, and I think Amy intimated this earlier, that the statutory requirement is for the board to make recommendations, if any, for legislative changes necessary to make prescription drug products more affordable in the state. So to that point, as long as you and the board can come to or find the nexus between access and affordability, and there is consensus for a recommendation to go forward, it appropriately can and should. But I just want to call that out, that honoring the spirit and intent of the provision in statute is to make prescription products more affordable in the state. If we can do Robert, and then we'll ask Chair Bailey to close out the conversation.
Thank you. So I'm totally aligned with where Amy was. I believe, with the exception of 192 and the PAP and maybe the copay accumulator, although I thought that was addressed in 4113 this past session. Everything else seems to be not focused directly on our mission, and I would really struggle to get my arms around this for a board and what we're intended to do.
Thank you, Robert, for sharing that. I'll just add a comment here. I do want to share that I'm actually the one that reincorporated language that we had from our legislative priorities last year related to pharmacy access and re-suggested those as bullets for this document. So I want to make sure that I just mentioned that these were some of the minimum dispense fees and pharmacy related issues related to access were things that even as a board were top priorities for us last year. So I just wanted to lean into that and also mention that, you know, there are 4 states that have identified, California, New York, Nevada, and West Virginia, that some of these issues related to minimum dispense fees for pharmacies don't result in increased expenses for payers. So I do feel there's a link between accessibility and drug affordability, which is what we're tasked with addressing. So I just wanted to make sure that our colleague, Mr. Murray, I was the one that pulled through some of this from what was on our legislative priorities last year. But I see there are 2 more hands. Should we, do we need to make a motion to extend the meeting at all? I do want to make sure we incorporate Dan and Vice Chair Burns' ideas related to this discussion.
I move to extend it.
We have a second to extend to the extent that we need it for public comment.
I'll second, yes.
Okay, thank you. So we've extended the meeting by 15 minutes. I don't know who had their hand raised next. I think it was Dr. Hartung. So you have the floor.
Excuse me, this is the interpreter. I just wanted to let you know that neither of the interpreters is able to stay an extended duration, so you won't have an interpreter for that time.
Thank you for the clarification. Ralph, if you can provide any guidance related to how
Yes, my guidance is going to be that we slice the agenda just a little bit and actually pause this conversation and incorporate public comment, because I want to make sure that anyone that is interested in what other folks in the general public have to say, that anyone that should require assistance be able to understand what that is. So I think that is probably the right call. Apologies if it is not, but why don't we pause this conversation? I think you said we have 2 or 3 folks signed up for public comment, honor that they may well have commitments and hard stops at noon too, and then circle back to this conversation.
Okay, no problem. Then I will move forward and reference that our next board meeting is October 16th, 2024 at 9:30 a.m. I would like to ask staff if you have any additional announcements.
We will forego announcements to ensure ample time for public comment for anyone that may need to leave at noon, and ensure that there is ASL services available for that section.
All right, well, thank you, Ralph. So this next portion of our agenda is for public comment submitted or requested in advance. The board received 6 written comments, which are posted on the board's website and were reviewed and provided to the board. I will now read who we received the letters of comment from. Mark Sterboyce, who's a consumer related to consumer cost factors related to capping drug prices. Scott Bertani from Health HIV related to affordability reviews. Matt Prokop, American Diabetes Association related to continuous glucose monitors. Seth Grenier from the National Multiple Sclerosis Society related to UPLs. Daria McGrew from Pharma related to the September 18th meeting materials. And Michelle Peters, Global Coalition on Aging related to PDAB. With that said, we did receive 3 requests to provide oral testimony. I will call on each person who signed up to speak and ask them to please state your name and organization. You will have 3 minutes to speak. As a reminder, I do want to reinforce that the board will not deliberate on any issues or requests during the time. But with that said, the first individual up to speak is Matt Prokop from American Diabetes Association related to continuous glucose monitors. Matt, I sincerely apologize related to the pronunciation of your name. So please correct me, but Matt, you do have the floor.
I'm just going to refer to the letter I submitted. I emailed Melissa that I was going to decline on public comment at this time. So just refer to the letter that I submitted for consideration.
You know what, and actually I was told that in advance, Matt, so I apologize for that. Melissa did let me know and I did not mark you off the list. So thank you for reinforcing that. So the next speaker here set to speak to the board is Richard Blackwell from Pacific Source Health Plans related to the policy recommendations for the legislature. Mr. Blackwell, you have the floor, and again, you have 3 minutes.
Not see him on.
Okay, thank you for letting me know. I believe that was Courtney. Then we will move forward to Daria McGrew from Pharma, speaking related to the September 18th meeting materials.
Good afternoon, good morning, board, confirming you can hear me.
Daria.
Thank you.
Welcome.
Daria McGrew, Director of State Policy on behalf of Pharmaceutical Research and Manufacturers of America, or PhRMA, pertaining to the UPL approach section of the meeting materials specific to pages 25 to 30. We've provided thoughts and concerns about various approach proposals as noted in our letter and in the discussion today. There isn't enough detail on any to fully understand how it would be effectuated. Of course, the board isn't at a point in this plan to be able to flesh out every single detail, and we understand that. On the other hand, as you all acknowledge, this is extremely complex and the devil will be in the details. Stakeholders who have significant technical expertise need to be able to meaningfully comment and can't do so without more detail on any or each of these plans. I note that your MFP repricing exercise isn't in the updated meeting materials, and we do ask that that be uploaded so that stakeholders can review. And I'd like to briefly speak to the UPL modeling report from OHA, which was added to the meeting materials after our letter was submitted. I strongly encourage the board and all stakeholders to fully read it, as it presents a far more nuanced analysis than was presented to you today. For OHP, their analysis said no savings to the state due to several factors such as CCO capitation rates and federal matching dollars. It's also worth noting that 90% of state employees are not expected to see any savings to their out-of-pocket costs. That should be noted. For state employee plan costs, the modeling may be found savings or maybe equivalent costs. The error bars were wide on either side. They stated that savings was possible if there were both an aggressive price cut and still rebates. I note that the model presented here and to the Cost Growth Board earlier this year from Horvath Health Policy stated that the UPL would repurpose rebates and therefore WAC minus rebate would equal UPL. That was the quote. I think it's a pretty big presumption that it might be realistic to assume both things are true at the same time, significant savings and retention of significant rebates. I also note OHA's pharmacy team further advised of several potential limitations and caveats, including but not limited to potential impact on availability of supplemental rebates, potential impact on federal Medicaid rebates and manufacturer best price for the entire nation, potential impact on 340B prices for the entire nation, and impact on access to medicine in the state. And all of these are very significant considerations that I know the board is already discussing and will continue to discuss. Thank you.
Thank you, Ms. McGrew, for your comments. While we do have just a couple minutes remaining, I did want to ask Ralph, can we address any additional comments that Dr. Burns or Dr. Hartung wanted to make related
Yes, let's resume. And
that? Because I only need about 30 seconds to wrap up the meeting.
yeah,
So
let's resume conversation as related to the policy recommendations, and then
I just wanted to make sure to capture their thoughts. So
yep, absolutely.
Dr. Hartung or Dr. Burns, if either of you would still like to provide those comments, you have the floor.
Yeah, just really quickly to kind of address what you were saying about the 4 states. The key word there that you said was dispensing fee. And what I'm trying to bring up here is that we have some very ambitious recommendations that isn't just dispensing fee that we're talking about, but tied to reimbursement rates, which is a lot. So I guess my suggestion would be that we are a little bit more tactical, and dispensing fees is something that might be a more manageable thing for the legislation to look at. I mean, honestly, when you get talking about just in such a broad way, like I'm not sure that we have evidence to support this. And I don't know that it fits with the PDAB when we're talking about, when you look at like, not just this one, but if you go down to the next page where it says minimum reimbursement and the minimum dispensing fees and then minimum reimbursement, that's a lot. That's very complicated. And I don't know that that's gonna fall into prescription drug affordability.
Thank you. I see, Mr. Judge, you added your hand. Dr. Hartung, did you want to add any comment related to previously when your hand was raised?
Yeah, I mean, I kind of wanted just to get on record that I endorse this notion of having a recommendation related to some sort of statewide minimum dispensing fee be included. And while I think, I think our general charge is about affordability, we also recognize, and I think we have a good representation of pharmacy on the board, that pharmacy is under stress right now, and we are going to be recommending in some fashion some fairly disruptive policies in the state that may in fact put more stress on pharmacies. So I feel having some sort of floor or backstop that somewhat protects pharmacies, because it is true that they're closing in Oregon and we have problems with access, I think seems reasonable as a recommendation that we put forth to the legislature, and then they can consider it. But that's kind of my thoughts.
Thank you for sharing those comments. Mr. Judge?
I just want to add to my previous comment. I haven't changed my position, but just wanted to let the board know that for the past 3 months, Representative Nose has been holding a PBM work group and pharmacy work group with the very focus of how do we fix and address pharmacy's stated issues. And I'm very confident that he has legislation in mind that will be introduced in the session. So if this is not a thing that the board picks up, which I do not think the board should pick up, I'm very confident that there's going to be activity that you'll see in the next legislative session that attempts to address this.
Mr. Murray, I do want to give you the opportunity to speak. We will have to wrap up the meeting.
I don't know if we have I think they have to go so that you can drop off. We don't need to have interpretation for this section.
Thank you very much.
Thank you so much. Okay.
Thank you. Mr. Murray, you have the floor.
Thank you. I disagree with the idea that this group doesn't need to make a recommendation if they see an issue that the majority of the group feels is important to the mission of the PDAB, I would like to see us vote and move in that direction. So I don't agree with relying only on legislation being put forward from Chair Nose, although I appreciate it. If this group feels it's important to advocate for one particular section of the 844 people that it's supposed to protect, I would appreciate it. I think it would be the right thing to do. Thank you.
Thank you, Mr. Murray. And Ms. Hoagland, you'll have the final comment and then we'll close the meeting.
I am very much in support of protecting local pharmacies. We spend a lot of money and time with La Clinica, federally qualified health center, delivering medicines to patients because of the difficulty of not having easy access to pharmacies in certain areas of our community.
Thank you for your comment. So with there being no further business before the board here today, all in favor of adjourning our board meeting, please say yes.
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 Any opposed, please say no. All right, with that said, I would encourage everyone to join us at our next board meeting on October 16th, 2024. Thank you.